All right, so ladies and gentlemen, if there are any gentlemen online, good evening and welcome to our Sunday evening session with Fibroid Awareness Trinidad and Tobago. This evening we have with us Dr. Cindy Duke, and this evening our session is titled Let's Talk Fertility. As I was sharing a bit earlier, and we shared before in previous sessions, Fibroid Awareness Trinidad and Tobago was birthed out of a very personal experience for me. And once I was diagnosed, I quickly learned that information was not so easy to come by, especially regarding fibroids. As a woman of color and as a woman of color in the Caribbean, that is where the challenge started. And so that really began the journey and it evolved into what we see today. I eventually had a myomectomy in 2014, and it was literally on my surgery bed that I started documenting things, and I knew that I wanted to share so that other women will have access to information that may not have been readily available. Fast forward to 2020, we got registered formally in 2018 and we started doing our work. We started going into schools. We developed something called the Confidence Project, which takes us into schools and communities. And we also started support group meetings. So we have these meetings face to face and we talk about a range of issues, health, food, diet, other issues of the uterus, because although we focus on fibroids, we also look at other issues of the uterus because there are many. And many times the symptoms are similar, so we started that journey. And as we were planning for a session for the first quarter of the year, COVID-19. And so everything had to shut down and we were basically thrust into the virtual space. And we started using the Zoom platform to continue educating women. And so we've had quite a few, and as you know, suggestions come in, we look for resource persons who would be willing to share with us. And so after the last session, I was like, fertility has been coming up and I need to find somebody to speak about fertility. And my cousin was like, you're going to Dr. Duke? I said, girl, to tell you the truth, my mind did not immediately go on Dr. Duke. God was just telling me somebody in the US. I don't know yet who it will be, but that is, and as she said Dr. Duke, I was like, oh my gosh, I'm going to reach out to her. I was biting my nails. Will she respond? Will she be able to come? I know she does her own thing online. She's very active online as a medical influencer. Would she have the time? And Dr. Duke was gracious and she obliged. And so she's here with us this evening for us to talk about fertility. So that's it in a nutshell. I am going to quickly introduce formally Dr. Cindy Duke, we Tobago girl, so we are very proud. So let me just quickly tell you about Dr. Duke and who she is and some of the work that she has been doing internationally. And then Dr. Duke will get into her presentation with us this evening. I am not too sure what her format would be, but I know whatever Dr. Duke is doing is going to be engaging. And we are definitely going to appreciate the information that she shares with us this evening. So let me just pull up the bio quickly and we can get into who Dr. Cindy Duke is. All right. So here we go. So about Dr. Cindy Duke. Dr. Cindy MP Duke is a medical doctor, trained physician, scientist, and entrepreneur who is board certified in gynecology and obstetrics, as well as fellowship trained in reproductive endocrinology and infertility. Dr. Duke is the physician founder, medical director, and lab director of the Nevada Fertility Institute in Las Vegas, Nevada, USA. She is also a PhD trained award-winning virologist whose research interests centered on the interplay of viruses with the human immune system. One facet of Dr. Duke's extracurricular work includes outreach to women and girls to encourage and foster their continued interest in careers in science, technology, engineering, and math. Dr. Duke is the host and producer of the Girl Powered Success and Survival International podcast. And this podcast is aimed at highlighting the work and the dynamic career paths of women and girls around the globe. Short but sweet ladies, let us welcome Dr. Cindy Duke. So on Zoom, you clap like this. Yeah? So let's welcome Dr. Duke. And thank you for joining us, Dr. Duke.
Hold on. Okay, I'm unmuted now. Hello, everybody. Thank you, thank you, thank you. Happy Sunday to everybody. I didn't prepare a PowerPoint because I thought we'll make this more of an interactive conversation. I'll start off with a presentation. So I'll tell you basically the statistics. We'll talk about options for treating fibroids, but then I figured the conversation should go in the direction, whichever direction you guys want it to go into. Really, no topic is off limit for me. And so I'm happy to answer questions, expound on things as we go along, point you to resources. I do have a virtual clinic based in Trinidad and Tobago as well. It's called the Trinidad and Tobago Center for Comprehensive Women's Health. I founded that clinic. At this point, we have 3 doctors who work through the clinic. I'm still the face of the clinic, but there are other people who work through the clinic, including a lactation consultant and a pediatrician. But, you know, I think everybody knows the basic statistics about fibroids, but I'll talk about them as they relate to Black women, Afro-Caribbean women, and fertility. So as everybody knows, 9 out of 10 women of African descent, so Black women, wherever you're in the world, will grow fibroids, but not 9 out of 10 women will have those symptoms for fibroids. About a third of them have symptoms. So for every 9 out of 10, 3 out of those 9 will actually show up to their doctor, their clinic, somewhere complaining of symptoms. And the symptoms, of course, are broad, right? The most critical and acute symptom that many women show up with is heavy bleeding, heavy periods, such that they're getting what we call symptomatic. So they're short of breath, they're anemic, they're lightheaded, they're dizzy, they're ending up in the hospital requiring blood transfusions emergently, or requiring to be on very high doses of iron in attempts to help their bone marrow make more red blood cells. Of course, the problem with fibroids that cause heavy bleeding, which are primarily the submucosal type of fibroids, is that you bleed way more than your body can catch up with in 1 month to replace the blood you've lost. And so you're always working at a red blood cell deficit, so to speak. So women who suffer from heavy bleeding related to their fibroids tend to have a lot of general symptoms that persist throughout the month and their life, and it starts affecting their functionality. It affects your energy levels, it affects your ability to work, it affects your mood because you're tired all the time. It actually can be confused with depression. You are unable to work out, exercise, you feel short of breath, you really feel like something's hit you hard. Fibroids, of course, are genetic. And so for a lot of us, when we tell our family members and our friends or close friends, and of course we know, Grapevine in Trinidad and Tobago, we're related to a lot of the people we know. They say, oh, that's normal, right? That's how people feel. But the truth is, they're saying it's normal because we've normalized these heavy periods, these heavy symptomatic bleeding episodes. But in fact, they're bigger, deeper issues that need to be addressed. But that's related to submucosal fibroids. Other symptoms, the general symptoms, relate to fibroids that just grow very large. And in one study done out of the Cleveland Clinic in the United States, they actually showed that women, particularly Afro-Caribbean women, were growing their fibroids to sizes that were 3 to 4 times bigger than the average size you were seeing in American-born women when you took all American-born women compared to Caribbean-born women. And I think most of you would agree with that. And for many of us, we just grew up seeing women with bigger bellies, right? We grew up not really thinking much about, oh yeah, you know, her belly looks like she's pregnant, but she's not. But there's actually data that says, you know what? We do. We grow them. We grow large fibroids, and it might be related to a number of things, including diet. It's related to delay in diagnosis. It's related to the fact that I certainly know for my mom, who I have documented, she has lots of fibroids. But I remember going with my mother to see the OBGYN in Tobago when I would have been 13 years old at the time. And he jokingly suggested that she needed to get a boyfriend, you know, whereas this woman was actually having heavy bleeding. This woman was having bleeding so heavy that she was having accidents when we're in town. You know, she couldn't go a couple hours during her period without a big accident, you know. And I remember being struck by those words, because of course I would never tell a patient that today. I would actually send them for an ultrasound, and I would evaluate what's going on with this heavy period, as opposed to suggesting that she wasn't sexually active enough and hence her bleeding. But I think while my story is one example, I know there are lots of other people from that generation who those were their examples. Those were their experiences. They weren't sent fast enough to get an ultrasound, to look at their womb, to map what was going on. I know from my own experience today, talking with young women all over the Caribbean and in Africa, many of them still are delayed in getting diagnosed. Here in the United States, they actually looked at the time it took to diagnose a fibroid in Black women and noted that although Black women have more fibroids, grow them larger, are more symptomatic from their fibroids, they're the least likely to get diagnosed with a fibroid compared to their white counterparts. And one of the big things that was noted was really it takes 2 to 3 years longer for a Black woman to get diagnosed with fibroids compared to a non-Black woman in the United States. And that study hasn't formally been done in the Caribbean or in Africa, but I suspect the numbers are the same, which is for many of you, you're probably coming across your fibroid diagnosis inadvertently or from your own online search and research, and really your own personal activism has led you to find that, you know what, I have fibroids. These symptoms sound like fibroids. I'm going to go back to my doctor, the clinic, my healthcare provider, and ask specifically, do I have fibroids, and is that what's causing my issue? So those are some of the symptoms, but other symptoms are bloating. Like I said, belly growing so that you're constantly having to change clothes or size of clothes or wear elastic waisted clothes because things don't fit your waistline the same way anymore. For others, it's constipation that came just progressively over time because you have a fibroid perhaps growing that's compressing your rectum and, you know, causing issues there. For others, depending on the location, if it's what we call subserosal, growing in the abdomen, they can grow to be quite large, size of a bowling ball even. Some people have indigestion, acid reflux, because it's displacing the stomach or pushing the stomach up. And so the symptoms can vary. For those coping with fertility, fibroids can have direct impact on your fertility depending on where they grow. The most common fibroid type that causes fertility issues is the submucosal fibroid, meaning the one that tends to grow and then have an impact on the cavity, the space in the womb where baby grows. Of course, those are the same ones that cause heavy bleeding or heavy periods. But specific to fertility, those submucosal fibroids can block sperm and egg from meeting each other if it's blocking the opening to the fallopian tubes, which is the place where pregnancy actually starts. It can also block a fertilized embryo from coming down and implanting in the womb. And so it can, just by being a space occupier, lead to an ectopic pregnancy, meaning a pregnancy getting stuck in the tube and unable to come down and implant in the womb. But let's say the embryo actually made it down into the womb. If it implanted over the fibroid, as it grows, it can run out of blood supply, and that can lead to a first trimester miscarriage. If it didn't implant on the fibroid, but within the womb, as a pregnancy grows, fibroids grow. And so as the pregnancy is growing, the fibroid grows along with the baby, competing for space with the baby, and actually lead preterm. If you're lucky, it'll be a delivery that's beyond 24 weeks, which means baby actually has a chance of surviving once born. But for a lot of women, about 25 to 30% of women who have fibroid related pregnancy loss, it happens before that 24-week, or what we call viability period. And so those are where you can see the pregnancy losses or the miscarriage at 20 weeks, 21 weeks, 18 weeks, you know. And these are some of the really heartbreaking losses, of course, because by then you can see a fully formed fetus, but it's born before the lungs are viable, and hence you lose your baby. And so those are ways in which fibroids can impact pregnancy. Another way is because a fibroid's growing with the baby, it can prevent the baby from turning as the baby gets really big. And so it can lead to a breech pregnancy, or a baby that's basically not presenting head first for delivery, which means then the patient, the mom, ends up needing a cesarean section, a cesarean delivery, to safely deliver that baby, because it's not head first. And so there are a number of things that can go on that pregnancy related and fertility related from fibroids. The truth is, if you suspect you have fibroids, if you're either someone in the category of heavy bleeding, you're needing blood transfusions, you have miscarriages, recurrent miscarriage in particular, which is diagnosed and defined as 2 pregnancy losses. They don't have to be back to back. You can have even delivered a baby in between, but 2 consecutive pregnancy losses. Part of the evaluation for that should involve looking for fibroids, specifically a submucosal fibroid, which is the fibroid that's growing within the cavity. Other things that should be done as part of the evaluation to know if your fibroids are impacting your fertility is, if you're found to have many fibroids, and an MRI, which is a magnetic resonance imaging, MRI of the pelvis, should be done to really look and figure it out. Treatment-wise, it all depends on your goals, right? So if you're someone who either plans to continue having children, or at least wants to have that option to continue having a baby or start a family, then you need what's called fertility preserving surgical procedures to address your fibroids. And that's critically important before you start talking to somebody about treating your fibroids. And so if you're talking to someone about fibroid treatment, your options are either fertility preserving, whether or not you think you're going to have kids, it's fertility preserving or not fertility preserving. So the standard general practice for care and cure of uterine fibroids is hysterectomy, meaning the removal of the womb. But of course, if you remove the womb, that is not fertility preserving. So actually, if you're someone who would like to have kids, that's why I'm saying the first thing you have to determine is whether or not you're mentally prepared for hysterectomy. Because if you're at all think you might want to carry a baby someday, hysterectomy is not the right choice. But then what are your alternatives? Not every other alternative is the alternative for fertility preservation. So we certainly don't recommend, if you think you might want to carry a baby in the future, doing uterine fibroid embolization. Fibroid embolization should be considered for someone who doesn't want surgery or is not a good candidate for a hysterectomy surgery specifically, but also is not yet prepared to lose the womb. However, it should not be someone who has an active plan to have a baby, carry a baby in the future. Options specific to carrying a baby actually involve myomectomy, which is surgical removal of the fibroids. The big thing to know about myomectomy is every single fibroid needs to be taken out if it's not safe. And by safety, I mean safety for you, yes, your life during surgery, but the second safety question is, where are the fibroids located, and would attempting to remove every single fibroid in that surgery increase the risk of you having a hysterectomy, meaning the chance of you losing your uterus? If the chance is really high, then certainly fibroid experts like myself recommend that the surgeon who's doing your myomectomy be a little bit more conservative, remove the fibroids that will directly impact your chances of pregnancy and your biggest symptom. So if your biggest symptom is heavy bleeding, then focus on the submucosal fibroids and any other safely removable fibroid, as opposed to rushing after maybe a tiny fibroid that's near the big blood vessels, the womb, or rushing after a fibroid that's literally connected to the tube and ovary, where it can actually cost you your eggs. And so it's very important when you talk to a fibroid removal specialist or a surgeon, it's important that you really clarify with them what your goals are. And I like to advocate that with patients, because sometimes we, the doctors, our goals are a little bit different from yours if we haven't talked about it, you know. For most surgeons, the goal is, how many fibroids can I remove? Let me just take them all out, less likely for recurrence. But as a patient, your goal most of the time is, I want to be able to get my symptoms resolved, but I also want to have a family. And we need to remember that when we're doing that. But I don't want to keep going on and on about things. I could keep going. I think let's open it up for questions, and then I'll expound as we go along based on